you. It's really lovely to be here. Nice to be outside of the Institute of Psychiatry and talking to kind of public health NCD people for a change as well. So today I'm going to present an overview of some of the interrelationships between mental health and HIV. So I'm going to present an overview of the research evidence and then move on to thinking about areas for future work and future priorities. So the talk is mainly going to be focused on adults and HIV. And it's going to be focused on issues that I think are important for low and middle income countries and evidence from those regions. And it's going to be mainly focused on common mental disorders rather than serious mental illness. So that's just to kind of give you an overview of what I'm going to be talking about today. So what do we mean when we're talking about mental health in the context of HIV? Well, evidence really suggests that depression is the most common problem amongst people living with HIV. But actually, if you do a search on PubMed, the articles are really, there's a big research focus on alcohol, but that's really around transmission and risk behaviours. And then that's followed by depression, and depression research is really focused on the impact upon HIV-related outcomes of depression, particularly focused on adherence. There's been far less work done on post-traumatic stress disorder and the serious mental illnesses. There is evidence to suggest that PTSD there is a higher prevalence among people living with HIV, and that may be associated with worse adherence. Similarly, with psychosis and bipolar disorder, the prevalence seems to be similar to that in the general population. However, there are particular risks associated with potentially retention in care, and recently some work's been done in Uganda to suggest that people with serious mental illness may be less likely to be retained within care. And HAND, so HIV-associated neurocognitive disorder. So this ranges from very mild cognitive problems to HIV-associated dementia, and that's associated with late-stage HIV/AIDS, so there's a biological pathway for that association. In general, less work has been done in terms of the effects of HAND on other HIV-related outcomes apart from morbidity and mortality. So what do we know? How big a problem is mental disorder among people living with HIV? Some of the best evidence comes from, so Bing et al. A little while ago now, 2001, carried out a nationally representative sample of people receiving care for HIV in the US, which suggested really quite high rates of depression among people living with HIV, and high rates also of anxiety, 16% anxiety, and high rates of panic disorder at 11%. So evidence from low and middle income settings, you can see it's really wide prevalence from this systematic review carried out in 2006. And basically there's a lot of heterogeneity, both in terms of prevalence, but also in the way that mental disorder is measured in low and middle income settings. So we don't really have a clear figure for the prevalence of common mental disorder in low and middle income settings, but we suspected it might be higher than among the general population. So this figure from Ciesla et al., this was a meta-analysis. So this was a lot of the studies carried out that compared prevalence between HIV negative and HIV positive people were very small. And it was only when they were meta-analysed and pooled that we were able to see that actually people living with HIV were almost two times more likely to be depressed than the general population. These studies were from the US. And finally, so some of the best evidence from low and middle income settings comes from this very early study by Maj et al. And this was a multi-site study that did show that people with symptomatic HIV had higher levels of depression than HIV-negative controls. So as I said, there's a biological pathway between HIV as a disease and neurological cognitive problems. And so HIV enters the central nervous system, and although ART and treatment will reduce this level and reduce the impact of HIV upon cognitive issues, it doesn't remove the problem entirely. So it's kind of, with the advent of ART, we've seen a reduction in the level of HIV-associated dementia in the West, where there's very high-quality ART, but it hasn't reduced the problem of neurocognitive problems entirely. And studies seem to suggest that the levels of neurocognitive impairment are somewhat similar in low middle income settings as compared to high income settings. So as I said, research around alcohol and HIV tends to focus very much on transmission behaviours and risk. So there's very strong evidence to suggest that alcohol is associated with risk behaviours, but also with HIV infection. So there's a meta-analysis of studies from Africa which suggested that alcohol use was associated with an odds ratio of 1.57 for HIV infection. And there's been other research, some very detailed research on kind of drinking venues, some qualitative research, which suggests that drinking venues may be associated with particular risk behaviours. So as places where people find non-regular sex partners and so on. So there is quite a strong association between alcohol and risk, as you might expect. However, there's been much less research done on alcohol in people living with HIV. So whereas all the research on depression has mainly been focused on people with a diagnosis, people receiving care, there's been very little research done on people living with HIV/AIDS and looking at their alcohol, their drinking patterns, and whether that has an impact on downstream HIV outcomes. Although there is some evidence from high-income settings that people living with HIV may have heavier drinking compared to the general population. There's very little evidence on this from low middle income settings. There is beginning to be some work around adherence and drinking among people living with HIV. So it's often quite difficult to disentangle some of these relationships between mental health and HIV. There's several different pathways. In some cases, I think common mental disorder can heighten the risk of HIV transmission, and then sometimes there are shared risk factors. So shared risk factors for HIV and for mental health. And then in some other ways, the risk behaviours in HIV and living with the disease may lead to a heightened risk of common mental disorder. So what this shows, hopefully, is the fact that people living with HIV face a number of life challenges, which can lead to risk factors for common mental disorder. And also these factors have kind of differential impact in terms of the stage of the disease course of HIV. So from diagnosis through to initiating care and treatment, and then stabilising onto lifelong treatment and care. And I think these factors, some of them are kind of impacting at an individual level, so things like disclosure and side effects and symptoms and so on, but there's also kind of these interrelationships with more structural level factors, stigma and discrimination, socioeconomic factors, and the availability and quality of services. And I guess what's missed off of this diagram really is kind of bigger structural factors such as poverty and gender, which also obviously interact with all of these things. So I think that these mechanisms are likely to be very complex. We don't really understand all of them, but I do think it's helpful to start to try to think about them, because I think they can be very important in terms of designing interventions and thinking about the timing of interventions, both for HIV and for mental health. So this really shows where we have the strongest evidence in terms of the associations between mental health and HIV-related outcomes. So the strongest evidence is that common mental disorder, so mainly depression, has an adverse impact upon adherence, upon morbidity, which leads to worse survival for people with depression. There's one of my own interests in terms of this work is around linkage to care and the effect of depression on the earlier part of the continuum of care, and we're just starting to get some studies that suggest that common mental disorder may have an impact earlier in the continuum of care. There is some evidence that alcohol has an adverse effect on adherence, and beginning to be some research in terms of morbidity. And then, as I mentioned earlier, neurocognitive disorders there is a very strong biological association with morbidity. Most of the research has been carried out among people living with HIV who are accessing treatment. which kind of sets the agenda for some of this research. So just to summarise some of this evidence, so we have strong and consistent evidence that depression has an adverse impact upon adherence. And in this first systematic review listed, the likelihood of good adherence was 55% lower among people who were depressed as opposed to people who weren't depressed. There's also very strong evidence to support the association between depression and morbidity and mortality. Those who are depressed have faster progression and worse survival. Alcohol use is associated with risk behaviour and transmission. That evidence is very strong, but there is some evidence that alcohol may be associated with disease progression. This may actually be partially a biological pathway having an impact upon CD4 count. But there is also likely to be indirect relationships in terms of adherence and a lot of unmeasured confounding going on there as well. As I said, HAND is associated with late-stage HIV/AIDS, and the extent to which these neurocognitive problems have an impact upon adherence is not known at the moment, although there is a little bit of research among older people that suggests that cognitive problems may inhibit your ability to adhere properly. So in terms of treatment of mental disorder in the context of HIV, really generally, it shows that the success of pharmacological treatments and psychological treatments are somewhat similar to how successful they are within the general population. So antidepressants, a pooled odds ratio in a meta-analysis showed that an odds ratio of 0.57 for depression. This was in placebo-controlled studies. And there is evidence of a moderate effect of a range of different psychological treatments for depression in the context of HIV. What we know very little about is whether these effects are sustained over time, and also the vast majority of this evidence comes from high-income settings. So, although what we've shown, what the evidence shows is that there is an impact of common mental disorder upon adherence, and that treatment of common mental disorder can improve symptoms of depression among people living with HIV. What there is less consistent evidence about at the moment is the impact of treatment of depression upon HIV-related outcomes. You would hope, given these associations, you would hope that if you treated the depression, you may well see an impact in the downstream HIV outcomes. Particularly, the strongest evidence would be around adherence. But perhaps surprisingly, this evidence is less consistent. So there are beginning to be some pilot randomised controlled trials. So most of the evidence comes from high-income settings, but there are and a lot of the trials that have so far been done, the studies that have been done in low and middle-income settings have been quite small. But there is emerging evidence from these pilot studies that we may be starting to develop successful interventions which have an impact upon adherence. In particular, and some of these are starting to be done in low and middle-income settings. This one, published by Peterson in 2014, was a small trial in South Africa, which I think will be scaled up into a larger RCT. So I think in the coming years, we will get more evidence about what works in low and middle-income settings in terms of mental health interventions. Interestingly enough, perhaps the strongest evidence comes from the Healthy Living trial, which was carried out in the US. It was a very big study with almost 4,000 participants. It wasn't it wasn't powered around mental health or HIV adherence outcomes. It was actually powered around reducing transmission behaviours. Interestingly, with this study, it kind of contradicts some of the stuff I've been talking about, but they found that this kind of CBT-type counselling intervention had an impact upon, it increased adherence at 5 and 10 months, so it's obviously doing something, but there was no impact upon depression. So that raises the question of whether actually you could do other kind of psychological interventions which would improve HIV outcomes, but you need to think maybe about how to do both at the same time. I think that question is still not fully answered. So before I go on to kind of summarise and talk about future questions, I just wanted to spend a couple of minutes talking about some of the work that I did in India. So I've hopefully presented an overview, but this is just a kind of example of one aspect of the relationship between HIV and mental health. So my interest is really around the associations between common mental disorder and HIV, but very early in the pathway to care for HIV. So the background to this work is that we had found that a lot of the research was focused upon mental disorder and adherence, and it was carried out among people who were already in care for HIV, and obviously have shown this strong association with poor adherence of people living with depression and HIV. And so our question was really, well, if we can see that there are shared risk factors for HIV and mental health, what is the prevalence of common mental disorder early in the continuum of care, and what kind of impact does this have before people are stabilised and in treatment and care programmes? There's very little evidence from low and middle income settings on this particular area, and so what we wanted to do was look at the effects of common mental disorder among people coming for testing, and look at the impact of that upon receiving test results and linkage to care. So that's really the first couple of gateways in terms of getting on to care and treatment programmes, are going for testing, which we didn't look at, but then receiving your test results and then making that first point of contact with ART treatment services. So this is the main research question that I'm going to focus on. This paper that's listed here is actually from one of our other outcomes, but I wanted to just present initial results for this research question, which is looking at effects of common mental disorder upon service use among people coming for testing. And these photos just show the kind of go-in setting, so it's a kind of peri-urban environment in India. So the methods for this study, we ended up in the end with just under 2,000 participants. It's a prospective cohort study, so people were recruited as they came for testing for HIV. We included a baseline survey which included measures of common mental disorder, but also we were interested in looking at cognitive impairment, and particularly the aspects of cognitive impairment which may be likely to have an impact upon service use. Follow-up data on HIV status, their attendance of post-test counselling and attendance of the ART centre were collected from clinical records, so it's a data linkage study. So I'm whizzing through this, but to move on to some of our results. So what this shows is that after controlling for confounders, when we looked at the association between common mental disorder and attendance of post-test counselling, common mental disorder was associated with 50% decreased odds of attendance of post-test counselling. Now, we didn't find any association between cognitive impairment and non-attendance of post-test counselling, and we only found evidence, very, very weak evidence of association between alcohol use disorder and attendance of post-test counselling. What we also did was we were interested to see whether people's HIV status, which was determined after we tested their mental health status, was an effect modifier of this association between mental health and attendance of post-test counselling, and we didn't find any evidence to suggest that was the case. So I think that in our study, it seems that there was an impact of mental health upon service use in this very early part of the continuum of care for HIV. We also, the second part of our analyses were to look at the association among those people who tested positive for HIV. We wanted to look at the association with linkage to the ART centre, so that kind of second gate on that pathway to care. So in the prevalence of HIV in Goa is relatively low among people coming for testing. So there were 11% of that initial sample of 2,000 were HIV positive. And 180, so eventually we had this cohort, a reduced cohort of 183 people who were HIV positive and received their test results. What we found actually was there was quite poor linkage to care in Goa at this time. A third of people who received their test results didn't attend the ART centre for follow-up, so that is a concern regardless of the relationship with mental health. our a priori hypothesis was that people with depression would be less likely to attend. When we looked at that diagnostic category, we didn't find any association. We did some post-hoc analyses, which is what is presented here, which is looking at basically symptoms of depression and their association with non-attendance. And we did find quite a strong association, although because these are post-hoc analyses, they are very tentative, but I think it means that this area is potentially worth having a look at, because linkage to care is an important part of the continuum of care, although most focus is on kind of further downstream on adherence, etc. So just briefly to kind of summarise the evidence. Is that there's a high prevalence of mental disorder among people living with HIV. Mental disorder seems to have an adverse impact upon HIV outcomes, particularly adherence. There is evidence to support the effectiveness of treatment in terms of improving mental health, but there's only emerging evidence of the effectiveness of treatments in improving HIV-related outcomes. These are just some of the future questions that I thought were important, which I don't think I have time to go into now, but just to kind of leave you to think about. I think there's lots of issues around kind of integration of both HIV, things are moving towards integration of HIV care and care for mental disorder into primary care. And so I think there's lots of questions in terms of which interventions we should be recommending, and then lots of questions around implementation, task shifting, and how best these things can be done without adversely increasing the burden upon people who work within primary healthcare. Okay, thank you.